So in this country, the NHS is obviously the main means by which patients access healthcare when they need it, and that's tax funded and it's free, largely free at point of use. But there is a parallel privately funded healthcare market that operates in this country. And if a patient wants to and can afford to, has the means to, then they can approach a private healthcare provider and arrange for them to provide some treatment to them. That might be quite a modest cost if they just want to see a consultant for a consultation, for example, a few £100, or it might be more than tens or £20,000 for a major piece of surgery, for example. And patients can pay for that in many different ways. They can just pay out of pocket if they want to access some of those services. They can take out a loan. Most private healthcare providers these days offer interest-free loans on their treatment. They can take out a private health insurance policy, which means that they'll pay a certain amount every month, and they'll hope that that private health insurance policy will cover the costs of their private treatment when they need it. And increasingly, employers are offering their employees health insurance, partial health insurance policies as well. So there are various means by which patients can access that privately funded market when they need it. Is there a problem, Rachel, with the sound?
You're okay with me. Lucy thought there was, but I think if nobody else thinks there's a problem, I think we're good. I'm okay.
So the question I've been wondering is about the extent to which waiting times for NHS-funded treatment might influence patient decisions to privately fund treatment. And I think that's quite an intuitive idea that might be the case, that patients might be more inclined to privately fund treatment if NHS-funded waiting times are long. But there's not an awful lot of data or evidence on that topic, and that's the question I've been looking into, trying to think through how we might model that effect and what the implications of it might be. So I have a few questions for you on Mentu. Maybe Rachel, if you go back to that for me.
Sure. So I'll share my screen again so you can see the results. So the only thing about someone said it might be a little bit echoey. But
is that better? I've just changed my microphone settings. Is that better?
Yes.
Great.
Yes, that's right. Okay. You sound much more professional. Not many joking. That's
Thank you. Sorry about that.
No, it's fine. I'll just share my screen. So we have, like, say, we've got 3 questions for people, and here's the first one.
So yeah, the first question is about whether your provider or ICB has plans to increase levels of activity so as to reduce waiting times for elective care. And I know that not everybody here is working for an ICB or a provider. But if you don't work for one of those organisations, but work closely with a local ICB or provider, then answer on that basis. So does your local provider or ICB have plans to increase levels of activity so as to reduce waiting times for elective care? So this is kind of the mainstay of elective care planning. You know, there are various means by which you might reduce waiting times, but one of the main mechanisms that people think about using is to increase levels of activity in order to reduce waiting times. And obviously there's an expectation on NHS bodies to reduce waiting times for elective care back down to the standard. Okay, I'm kind of slightly surprised by that result. I have to say, I would have thought most people would have answered yes here, that they would have that there are plans going on within their ICB and provider to try and manage down waiting times by increasing activity levels. That's but that does seem to be, of those that have an answer to the question, that seems to be the dominant answer, I think. Shall we move on to the next question, Rachel? So the next question I have for you is whether you think whether waiting times for NHS-funded elective care might influence patient decisions to privately purchase treatment. To what extent do you think that might be the case? So I think we're getting a pretty clear-cut answer to that question. And although there isn't an awful lot of quantitative papers on this topic, lots of the qualitative research would suggest that waiting times for NHS-funded care is an influence on these decisions to privately fund treatment. Okay, and then if I move on to the last question. So do your provider and ICB plans for planned care include assumptions about the percentage of patients who will privately fund treatment in the future? So in those plans that your provider and ICB are working up, do they take account of this issue about whether or not people will privately fund their treatment now or in the future? And again, for those who haven't answered the question, it looks like the answer is probably not here. And that's been my concern, really. That's the thing that's been troubling me and that motivated this piece of work that I'm going to talk through with you now. So Rachel, would it be okay if I started sharing my screen at this point? Would that be okay?
Yeah, so just before you do, I'm going to put the next slide on, which I hope is, yeah, so this, I've just put that on for people who have any comments through your for your presentation, and some people can't access the chat. So it's just, I just popped that there. So yes, please do share your screen. Thank you.
Thank you. And I should say that I won't be looking at the chat while I'm presenting. That's too much for me. I won't be able to manage that. So, but I will look at the questions in the chat afterwards. If that's right. So sharing my screen. Rachel, can you see the screen share now?
Yes, perfect.
So let me just go back over that question that we've just been talking about. I think for the most part, providers and ICBs have been working hard over the last few months and years to work out how much additional activity they need to fund in order to bring down waiting lists and waiting times. And as I said, that's not the only means by which you can bring down waiting times. You can do waiting list cleansing activities, for example, removing people off waiting lists who no longer require treatment. You can try and manage down referral rates, or at least growth in the referral rates. But I think the main strategy that providers and ICBs use when they're trying to bring down waiting times is to increase the level of activity they fund and deliver. Now that process of working out how much additional activity you need to do to bring down waiting times to a target level, to 18 weeks or something like that, is not straightforward, but there are established methods for doing that. And I think most providers and ICBs understand those calculations they need to do to work out how much additional activity they need to do to bring down waiting times by a certain level. But most of you are also acknowledging that if we bring down waiting times for NHS-funded treatment, then fewer people in the future will privately fund their treatment, because the NHS option becomes more attractive at that point. So the people who are trying to decide whether or not to privately fund treatment are weighing up whether it's worth spending money, either now or by increasing your future healthcare insurance premiums, in order to get access to care quicker. And if NHS waiting times come down, then that decision becomes more finely balanced. And maybe there's a question about is whether is it worth me spending £15,000 on this treatment if it means only waiting a few extra weeks to get it on the NHS. So if waiting times for NHS funded treatment come down in line with our plans, then fewer people will privately fund their treatment. And that means that there's more that the NHS needs to fund as a consequence. If people aren't privately funding their treatment, then the NHS will pick up the tab for those treatments in the future. So we have this reinforcing loop, which starts with providers doing more activity to bring down waiting times, but in doing so is inducing more demand for those same services. And I'm worried that we're doing a lot of work on that top part of the loop to work out how much additional activity we need to do to bring down waiting times, but perhaps we're not sighted on the bottom half of the loop. And the consequence of that means that you might increase levels of activity to bring down waiting times, but you won't get all of the effect that you're hoping for, because some of the extra activity that you fund will be treating those patients who would otherwise privately fund their treatment. So that's the dilemma I've been working with. I've been trying to work out whether or not that bottom half of the loop is something we need to worry about or not in our planning for elective care. Now, I think there's a couple of questions. If we're going to answer that question about how important that bottom half of the loop is, we need to know whether that relationship between NHS waiting times and patients' decisions to privately fund treatment, whether that relationship is strong or weak. If NHS waiting times only exerts a very minor effect on patient decisions, then maybe that bottom half of the loop doesn't really matter. And similarly, if it's very rare for people to privately fund their treatment, then again, that bottom half of the loop becomes, we can probably ignore it. So if that relationship is weak and the extent to which people privately fund treatment is rare, then I think that bottom half of the loop we can kind of imagine is negligible, have a negligible effect, and we just carry on the way we ordinarily estimate future levels of NHS funded activity. But if that relationship is strong and people commonly choose to privately fund treatment, then I do think that bottom half of the loop becomes important. I think we need to start taking account of it in our models. So given this was a fairly novel piece of analysis, that not something I'd looked into before, I wanted to do it on a topic or a condition or a service line where I could get really good and clear data. What I decided to do was to approach the National Joint Registry for information on hip and knee replacements that have taken place over a 10-year period. So the National Joint Registry holds individual record level data on hip and knee replacements and other joint replacement surgery that's been carried out. They've been holding data for a long time, record level data, and importantly, they have data on people who privately fund treatment as well as people who are NHS funded, and that's a bit of an exception. There aren't many data sets we have where we have really good information about the extent of privately funded treatment in detail, at least. So I approached the National Joint Registry. It took a while to get the data, but eventually they agreed to give me the data for this project, and I've been working away on that project ever since. So just to give you a bit of context on the volumes, so if we think about hip replacements that took place in 2023, we can think about carving them up into 4 discrete boxes, broken down by who provides the care. Is it provided in an NHS hospital or a private sector hospital? And who funds the care? Is it funded by the NHS or is it funded privately through one of the mechanisms that I spoke about before? So before I show you the numbers here, maybe just imagine what you think the answer is in your head about how the volume of hip and knee replacements in 2023 were distributed across those 4 boxes. So that when I show you the results, you can some sense of whether it's surprising or not. So in 2023, about 44% of all primary hip replacement surgery was funded by the NHS and delivered in NHS hospitals. About 31% was funded by the NHS but delivered in private sector hospitals. And these are the sort of, we commonly have information about this set of patients because they flow through to SUS and HARES, all the data sets that we're used to seeing. But in 2023, 23% were privately funded and took place in private hospitals, and 1.5% were privately funded and took place in NHS hospitals. So about a quarter of all hip replacements in 2023 were privately funded. So it's not a rare occurrence for people to privately fund this sort of treatment. Just to give you a sense of how that's changed over time, so the colours match up here, so you can see how the 4 quadrants have changed over time. So you can see that between 2013 and 2023, the NHS-funded, NHS-provided market has dropped considerably. The NHS-funded, privately delivered market has grown steadily, and the privately funded, privately delivered market grew slowly until COVID and then expanded quite substantially after the COVID pandemic. And I have a similar chart here for knee replacement surgery. Similar sort of pattern, although the level of privately funded, privately treated knee replacements was about 20% of the market for knees, 25% for hips. So it's certainly the case that this bottom question, at least for hip and knee replacements, it is something we need to worry about. The privately funded market in hip and knee replacements is quite considerable. So the question now is whether the relationship between waiting times and privately funded treatment is strong or weak. So a little bit more contextual information. So the rate of hip and knee replacements in this country has been growing steadily. It dropped considerably during COVID, and has picked back up again, and we're roughly back on trajectory now for hip and knee replacements, doing more than 100,000 hip and knee replacements every year. And the bottom chart shows the proportion of those hip and knee replacements that are privately funded. So you'll see it's been creeping up a little bit between 2013 and 2019, then it's increased substantially with and after COVID. It's been dropping back a little bit in the last few years. And the other bit of context to set alongside this is our waiting times data. So this chart shows the proportion of people that are waiting less than 18 weeks for an admitted T&O pathway. So that's been dropping back from about 80% to about 37% in 2023. So the question is whether those bottom two charts are related. Is it the case that more people are privately funding treatment because of waiting times? And we can intuit it from these charts, but to be able to demonstrate it and quantify it, we need to do some modelling of the effect. So there might be other factors at play here that we need to take account of, in particular changes in case mix that we need to think about. So this is our sort of conceptual model. We're trying to model whether or not a patient who needs a hip and knee replacement chooses to go down the NHS-funded route or the privately funded route. And I'm thinking about any of those privately funded routes, out-of-pocket, insurance premiums, health insurance premiums, employer schemes, family loans, etc. What do we think influences that decision? So our sort of base assumption is that the individual's ability to plays a large part, but their sex and age and health status might also influence that decision. When they're taking that decision and where they're taking that decision might also be important. Some parts of the country are awash with private sector providers, others less so. And if travelling is an issue, then maybe where you live will influence this decision. And then we're interested in whether, having taken account of those factors, whether NHS waiting times also influence your decision to privately fund or go down the NHS-funded route. So we're trying to work out the influence of waiting times, having control for those other factors. And we might expect that the extent to which waiting times influences people's decisions to privately fund is moderated by things like ability to pay and sex and age as well. Now, we don't have good data, record level data on ability to pay, so we kind of proxy that with IMD decile, deprivation decile of where the person lives. I know that's not perfect, but it's a relatively frequently used proxy for ability to pay. I wouldn't
set it up for the photo, but I'll have the one before actually, because it's I did look. You can take it up if you want.
And then I don't know who that was, Rachel, joining in there. And then we don't have data on patients' health status per se, but we have this ASA score, which is a standardized measure of people's operative risk before they have surgery. So that's the sort of model we have in our minds when we're trying to estimate the impact of waiting times on patient decisions. And the data set is good. We have about 1 million records for hip and knee replacements and about 1 million records for knee replacements over a 10-year period from April 2013 to December 2023. And just to show you a bit more about the model that we're building, so we're trying to estimate this outcome, whether a patient privately funds treatment, and we're interested primarily in this exposure to NHS waiting times. And we're interested here really in the waiting times that the patient was experiencing at the time they had surgery in the area where they lived. So what was the NHS waiting times in that area in that quarter when they had surgery? And we want to control for these covariates: health status, year, where they live, ICB, age, sex and deprivation. And I mentioned before that we allow in our models for the relationship between waiting times and privately funded treatment decision to be moderated by age, sex and deprivation. So we allow the relationship between waiting times and the decision to vary by age, sex and deprivation. And most of this data that I use in this model comes from the National Joint Registry, but I also then built in or connected that to the RTT data so I could work out what the prevailing waiting times were for the patient. The outputs of the model take the form of a set of odds ratios. I know this is quite small now, so maybe apologies if you can't read, but we get a set of odds ratios for each of the variables in the model, which tell us whether a patient is more or less likely to privately fund treatment, having control for all the other variables in the model. And we have those odds ratios for sex, for age group, for decile, deprivation decile, health status year, and waiting times, and the 3 interaction terms in the model. And the sort of headline finding here is that the 2 main variables that influence patient decisions about whether they privately fund treatment, as you'd expect, are deprivation decile, their ability to pay. A patient living in the least deprived decile is 10 times more likely to privately purchase care than someone living in the most deprived area, having control for other factors. And the second most important factor is NHS waiting times. So if a person lives in an area or needs treatment at a point when NHS, almost everybody waits more than 18 weeks for their treatment, they are about 7 times more likely to privately purchase healthcare than a patient who lives in an area where nobody waits more than 18 weeks for treatment on orthopaedic pathways. And I want to give you a sense of how that works in practice. So in this chart, we're showing that on the horizontal axis, the percentage of people that in that local area who wait more than 18 weeks for NHS-funded treatments. And on the vertical axis, I'm showing the proportion of people that choose to privately fund their treatment. So these are the modelled effects, our estimated effects from the model. So in the baseline year, in 2023, about 20% of people choose to privately fund knee replacements, and about 25% choose to privately fund hip replacements. And the prevailing average waiting time in that period was about 62% of people waiting more than 18 weeks. So if we make waiting times worse or better, how do we expect that percentage privately funded variable to change? These are the model results. So if everyone waited more than 18 weeks for treatment, then we would expect about 42% of patients to privately fund their treatment for their knee replacements, and about 55% to privately fund hip replacements. And if nobody waited more than 18 weeks, then it's about 5 or 7% of patients would choose to privately fund treatment. That's what our models are suggesting. So it's really quite a substantial effect. So it's no small effect we're finding here. So it is something I think we need to be worried about or concerned about in our activity models. And just to give you a sense that that relationship does vary depending on whether the patient is male or female and the deprivation in which area in which they live. The shape of the curve is similar for all patients, but it's higher or lower depending on where you live in terms of levels of deprivation. And depending on whether you have a hip or knee replacement and whether you're male or female. So we have slightly different effects depending on which patient we're talking about. So I think we've got good evidence now that for hip and knee replacements, certainly, it's common for people to privately purchase treatment, and their decisions to privately purchase treatment is strongly influenced by NHS waiting times. I just want to give one more bit of information that came out of the model, which we weren't expecting really, and that's that we remember in our modelling frame we had this variable for year, so we were trying to say having control for waiting times and for patient case mix variables, were patient decisions to privately fund treatment changing over time? Were they more likely now than they were in the past to privately fund treatment, even after we control for case mix and NHS waiting times? And the answer is that for several years, between 2013 and 2019, those variables, case mix and waiting times, were good enough to explain patient decisions to whether or not they privately funded treatment. But since the pandemic, the level has changed. There's been a shift in the patient's propensity to privately fund treatment, even after we control for case mix and NHS waiting times. And in 2021, patients were twice as likely to privately fund treatment than they were in 2019, even after we control for those other variables. So that's a really important question here about what is influencing patient decisions to privately fund treatment. If it's not waiting times, only and case mix, what else might it be that's influencing those decisions? Now, it could be just that we've poorly specified our waiting times metric. We're using the percentage of people who wait more than 18 weeks for treatment, but it may be that patients are using a different metric as their signal for whether or not they should privately fund treatment. Maybe median waiting times, for example, 95th percentile waiting times. It might be something else other than that. It might be that patients are overestimating waiting times for NHS-funded treatment. There's a lot of stuff in the media about how long waiting times are. There's all this debate about the broken NHS, and I wonder whether, to some extent, patients are overestimating NHS waiting times, and that will be leading to bad decisions on their behalf to privately fund treatment, suboptimal decisions. It may be there's been a change in social norms, and what used to be quite a rare occurrence has become more common during the pandemic. I've heard some people say that they choose to privately fund their treatment to alleviate pressure on the NHS. So they're doing it socially motivated to alleviate the pressure on the NHS. So it may be that something like that is going on at the moment as well. And it may also be that people's ability to pay relative to deprivation has changed. And there was some research that showed that immediately after the pandemic, people had more disposable income because during the pandemic, a lot of people were furloughed and they'll continue to get their salary, but they had very little opportunity to spend that money because they couldn't go out, socialise and things like that. So couldn't go out for meals. So they accumulated quite a bit of additional wealth, a few £1,000s per person, they estimate. And it may be that that additional income they accumulated over that period gave people an ability to privately fund treatment they wouldn't previously had. Now, after that, obviously, we had the cost of living crisis and all that's been eroded and more. But at least for a period of time, maybe people did have more ability to pay for these treatments than they used to have. So I think through the analysis, I'm feeling quite confident that at least for hip and knee replacements, this is a factor that we need to consider. But I want to give people a sense of the scale of the effect now on their plans. So let's imagine we want to try and estimate how many additional joint surgeries the NHS should expect to fund if it can manage to bring down waiting times back down to the 18-week standard. So for hip and knee replacements, we're talking about an additional 11% for hip replacements and additional 7% for knee replacements. So quite a substantial extra level of NHS-funded activity that we need to accommodate if we manage to bring waiting lists down. And I think, for my part, I think we need to be planning on additional levels of activity based on the observed relationship between waiting times and privately funded treatment. Now, there's an additional question, which is that if this blip in people's propensity to privately fund treatment comes back down to 2019 levels, having adjusted for waiting times and case mix, what would that look like? And that's even more frightening. We're talking about maybe a 20% increase in the number of the number of NHS-funded hip replacements we need to carry out, and 12% increase on knee replacements. So this isn't a small effect we're talking about. And I certainly think for hip and knee replacements, this should be part of our calculations in the future about how we understand how much additional activity we need to fund in order to bring down waiting times. We need to take account of this secondary effect that's going on. So just a few sort of implications. So I think the NHS needs to plan to fund a considerable number of additional procedures if it succeeds in reducing waiting times. The ability to fund treatment obviously is compounding pre-existing inequalities in access to those treatments. So even at baseline, people living in more affluent areas are more likely to get an NHS-funded hip and knee replacement, having control for case mix, than someone living in a more deprived area. There's lots of evidence that suggests that's the case. I think I might have talked about that in a previous huddle. But obviously people living in more affluent areas also have the ability to privately purchase treatment, and we don't see that in our NHS data sets. If we were to take account of that, then the inequalities will be even more sharp. And there's a small proportion of people who live in the most deprived areas who are choosing to privately fund a hip and knee replacement because of prevailing waiting times at the moment, and that should be something that we're really worried about. So these people already have suboptimal access to hip and knee replacements on the NHS. Waiting lists are tight. They can't afford it because they're living. It's going to be a big issue to pay for a hip and knee replacement for them, but they are still, in some cases, choosing to privately fund treatment to get it. So we should be really worried about that, I think, in the NHS. And then there's this step level in patients' propensity to privately fund treatment that occurred after the pandemic, and I think we need to do more to understand why that's the case and whether it's likely that patients' propensity will return back to pre-pandemic levels, because that makes a big impact on our planning decisions. So I've been talking here about hip and knee replacements. Obviously, there's lots of forms of elective treatment, and I think we need to test whether or not this sort of relationship holds for other forms of treatment. And I would suggest we look next at cataract surgery, which is also, I understand, quite heavily privately funded, and increasingly diagnostic imaging. Patients are increasingly going to the private sector and paying for a CT scan or an MRI scan because they're waiting too long for the NHS. So I think those are the things I would look at next, whether or not this relationship holds in those other areas too. And there are a few limitations that I should go through in the study. I won't go through them in detail here for you to read if you want to. Happy to talk about those maybe through the chat and in discussion. I'll hand back to you, Rachel, to introduce others back in and to work through the questions people have, comments people have.
Thanks very much, Stephen. That was a really interesting walk through, and just adding, I love those charts at the beginning, by the way. I think they really effectively show the proportions in each of the different quadrants. Yeah, so I think people, like you're saying, intuitively people think and probably prove right that there's that strong relationship between waiting times and their decision to fund privately, but there's so much more to it than that, isn't it? And I think that's what you try to incorporate in this model. So there's been a couple of questions which I'll just share now on Menti, a couple you've already covered. But if I just sort of go to the top, so if you can just pick these ones out and you can see which ones you've already covered, starting from top left.
So yes, that first question is what rate of individuals and associated demographics are able to privately fund treatment? And this will vary by specialty. Yeah, so I do expect that. I think I picked out the form of surgery where this effect is probably strongest, because I haven't. There is a very strong private sector market in hip and knee replacement surgery. For other more complicated forms of surgery where there are greater risks, for example, that you might need to have intensive care after surgery, or then I think the propensity to privately purchase will diminish. But we just don't know that well enough at the moment.
Yeah.
I think that is something we need to explore in more detail. There is the Private Health Information Network, I think it's called, which publishes data on levels of private sector provision by specialty and consultant. It's an emerging data set, and I think will give us more and more useful information about the extent of this privately funded market in the future. It's not as detailed as I would like, but it's a start, and I think we need to maybe use that to get a better handle on the extent of this privately funded market in the future.
Okay. So this one here. So this is yeah. Okay.
So work provided insurance won't see a patient switch. It's the independent funding. Were you able to split this out? No, I mean, we don't have, unfortunately, in the National Joint Registry data. Then we only get data on the form of funding, not whether it was NHS or private. We don't get the detailed breakdown beneath that. As far as I know, National Joint Registry don't collect that data. It would be useful to see that, because I think you're right. The types of treatment that are more likely to be affected are the ones, the out-of-pocket funded treatments. Those that are funded through private health insurance, probably next likely, because if you draw on your private health insurance schemes, then your premiums are likely to go up. So there is a financial consequence of having treatment in the private route. I suspect that's less the case for these employment funded schemes, but I don't know much about those, to be honest. I don't know whether other people on the call know about those schemes and how they operate, but I would guess that the relationship is strongest for the out-of-pocket funded private treatments and less so for the insurance funded options. But of course, there's a secondary effect here, which is that as waiting times increase, people are more likely to take out those private insurance schemes and therefore more able to rely on them. So although in the moment, the financial impact of privately funded, going down the privately funded route is minimal if you already have a privately funded scheme, people are more likely to take out private health insurance in a context where NHS waiting times are long. Could this analysis be done at a more local level? Yes, I think absolutely we have. If you can get hold of the National Joint Registry data or get hold of this information from other routes, then absolutely you could. There's plenty of data. I mean, there's as I said, 1 million records that I had for hip replacements and 1 million records for knee replacements. There's plenty of data to support the analysis. In the models I built, I had ICB as a random effect in my model, so I wasn't able to estimate the individual ICB effects. I was just sort of taking account of it as a nuisance variable. But I could have had ICB as a fixed effect, and then I would have had the extent to which this issue applies by ICB. That's certainly possible. And you could build models, stratified models at ICB level as well, which is or trust level, for example, if you wanted to. I think the data would support that.
Yeah.
Intuitively, I think this effect is going to be greatest in areas that have at least a significant proportion of people living in more affluent areas. So if you're living in somewhere where it's all predominantly deprived, almost exclusively deprived, then I think this effect again is probably negligible. If you're living in an area of low deprivation or an area of mixed low and high deprivation, then I think this is something you probably need to think about modelling locally.
And I think just having the information at those local levels, whether it's ICB or trust, it just helps in terms of planning and sharing the message with people who need to know this. I think it just helps to sort of quantify it a bit, just to see how much it is an issue locally, and then it helps people to sort of register the importance of it and so on. So the next one here, so it says, aren't the doctors working in the private sector also working in the NHS? And if so, isn't it net zero sum? So isn't it a net zero sum game? In terms of the capacity.
Yeah. Well, there are debates about this. There are some doctors who work only in the privately funded market, but I think that's a small number. I think a lot of NHS surgeons and consultants also take private patients on to top up their income. Now, I think some of those doctors would argue they do this over and above their contracted consultant hours, and so perhaps, and they work full time for the NHS. And in that case, maybe the trade-off is minimal between their privately funded and the NHS funded activity. But I certainly think it is the case, and it's even more the case these days when we're purchasing such substantial proportions of activity from the private sector, when the NHS is purchasing that activity, because that would certainly eat out. There would be a trade-off between the NHS funded stuff happening in the private sector and the privately funded stuff happening in the private sector. And yeah, I think this is another effect that we probably need to understand more in detail. I know people have looked at this in the past, but it's the sort of thing you need really good data to try and pin down. Again, intuitively, it feels like there's an effect there that we need to explore, but we need to do the hard work to prove that's the case. If you're interested in that topic, I'd recommend reading the work of Alison Pollock. She does lots of work on this area where she tries to illustrate the unintended consequences, negative consequences of the NHS engaging more and more with the private sector for its treatments. So this is an issue I know she's concerned about. She's shown various other unintended negative effects of the NHS increasingly subcontracting to the private sector. So Alison Pollock, I'll put her name in the chat if you're interested in.
Yeah, definitely. I'll try and find a link for that and send it out sort of post Huddle. Yeah, I think when I looked at this is like so long ago. I think contractually there is a you can only have a certain proportion of your work which is private. So it's recognised consistently that consultants, surgeons, etc., will do private work, or many of them will do private work as well as their NHS workload. But there were restrictions in terms of how much that was. But I imagine, you know, as with everything, there'll be in terms of enforcing that and so on, that would be quite a difficult thing to do in some cases. So it's interesting. There's always a knock-on effect. So just moving through some of these other points here. So hip and knee replacements were chosen. I think you've covered this one, I think, but partly because of the good data. But so just remind us, you just mentioned cataract.
I think cataract surgery, I would go with, and I would look at diagnostic imaging. I think those are the two areas I'd look at next. There are other joint procedures as well, aren't there? Ankles and shoulders and wrists and things, I think, as well. Work can be done on. So I think there are other areas as well that are collected by the National Joint Registry. So they would be relatively low hanging fruit, although they're done in smaller volumes, I think.
So Sarah
yes,
mentioned
cataract is very high volume, diagnostic imaging very high volume, and I think the private market for those is substantial these days.
Just sort of on that, well, Sarah's mentioned something about cataract surgery in the comments. So she's saying private cataract surgery allows the option for different lenses, rather than like white fillings at the dentist. I wonder how much effect on decisions go to private those options have. So it's looking at the different levels that you have, I suppose, in those as well. It's like I went to so dentists, if people don't know, if you go to an NHS dentist, if you're lucky enough to be able to have one, they fund the amalgams, the metal ones, but unless it's visible, then it is. I've got that the wrong way around. But anyway, the rules have changed. Metal is bad. They're supposed to fund everything. So I'm having that conundrum with my dentist at the moment, but that's a different topic. But it's definitely relevant. So there you go. But in terms of all the those diagnostic treatments and investigations being more accessible, like you say, to and private, being privately funded, that's getting in the door. But then so all the treatments and we've done some other studies on this, haven't we? The increase in the levels of diagnostic, the diagnostic part of the pathway, and then of course you've got the actual treatment part of the pathway to come, and so you could be creating a bottleneck because lots more people are coming through because you can afford that bit,
Yes.
go to this, and that's how it's sort of maybe portrayed. You have your outpatient appointment in 12 weeks, or I can see you tomorrow in my other clinic. Anyway,
yes.
Okay.
No, I think you're right. People pick off bits of the pathway, but then return to the NHS for maybe the treatment bit of it.
Yeah.
So they would have their consultant outpatient appointment privately, and they would have their diagnostics done privately, but then ultimately come back to the NHS for the treatment. I think that's happening more and more. Sort of what was it called? Mix and match sort of approaches.
Yeah, pick a mix.
Pick a mix. There you go.
Yeah. Yeah, absolutely.
And I'd be interested to know whether people have got other ideas of other treatments they think are substantially privately funded that we should look at as well. So I've mentioned cataracts and imaging, but if people think there are other high volume privately funded treatments that we should consider as well, I'd be interested to hear people's views on that.
Yeah. So I'm just looking at this one. So deprivation, interested in work-based. Have we looked at this one? Insurance on the under-deprived population. Also thinking more manual work, push out of workforce, and need the operation to work. So there's lots of reasons why some people would need to have certain procedures and couldn't wait because of their impact on their livelihood and so on.
Yeah. And there's all that huge swathe of people these days who are employed on 0-hour contracts or these sort of slightly more substantially less secure forms of employment. They certainly wouldn't have access to those employee schemes, work-based schemes. And my guess is anyway, even after you take account of those people, that it would be the more affluent people who would have access to these employee-based schemes than more people living in doing more manual work, who are the ones who probably need it the most.
Okay. So we've probably got time for a couple more before I just finish up. So this one here, for deprivation, did you use the overall deprivation rank or the income domain of the score?
Yeah. That's a really good suggestion. No, we didn't. We used the overall score, not the income domain. And I know these things are broadly correlated, but intuitively, it would have been better, thinking about it now, to use the income domain score. The work we've done has been submitted to a journal for review. I wouldn't be surprised if one of the reviewers points out exactly the same issue. So that's maybe more work that we need to do. And I guess if anything, we're going to get a stronger relationship with the income domain than using the overall domain.
So
very interested in age. I know people waiting for cataract surgery that would benefit from going privately can afford to, but won't because they expect the NHS to provide. Yeah, we did have age as a variable in our model, and we found some very peculiar relationships that I didn't really understand and I didn't describe in this talk because I didn't feel like I had a narrative for it. But yes, I don't. I think there might be something quite odd going on with age. I think it might be generational as much as age. I think this is what the person asking the question is suggesting, something to do with people's attitudes towards the NHS and what it should do for them may change by generation rather than by age. But that will be expressed as age in the data sets, won't it? In any given year.
Yeah, so these people have paid in.
Point.
They've paid for this. Now they're going to get their money's worth.
Yeah.
Quite right.
Exactly.
There's a comment in the so Zoe's made a comment in the chat which I'll read out for people who can't see it. You can see it, Tim. So in mental health, ADHD, and autism assessments, follow-up medication is not taken by NHS, so it's much less pick and mix decision. Also, substantial NHS costs in patients use right to know for children and adults. So there's lots of different sort of areas where there are different sort of things at play for some of these things as well. So that's a
good call, Zoe. I think that's good suggestions. More difficult to get good data on, I suspect, at the moment. But I think you're right. If we're going to see effects, it could well be in those areas.
So do you want to pick one more from the 4 that you see on the screen at the moment? Pick one more bit before I. Shall I
pick the pandemic one? So pandemic, guessing a chunk of patients who are waiting pre-pandemic and just reached a point where they couldn't wait anymore. Yes, and that may be to do with so I guess this person is getting at why we saw that jump in people's propensity to privately fund having adjusted for waiting times. I think that could be the case.
Okay.
There were people who were just about presumably to have surgery when the pandemic came along, and that would have got pushed back quite considerably at that time. Maybe that was just a tipping point for some people, and they chose to bite the bullet and pay for it at that point. And that's a good call.
Okay, thank you. So what I'll do now, so there are a few more questions, and as we've been talking, a few more have been added. So if I share these with you after the session, and if you could maybe provide some sort of brief responses to the ones that you haven't answered during the session, that would be much appreciated. I know people do want more time on questions, and sometimes it's difficult to get that balance right between sort of content and sort of being able to respond to them, but I do promised if I get answers, I will share them with people. I don't gatekeep. I would never do that. So thank you ever so much for I'll just stop sharing. Thank you very much for going through that with us, Stephen. I really enjoyed the way that you've approached the analysis, and I'm sorry that person pointed out the potential flaw in your approach and flipping income IMD element, but there might, like you say, that'll just make the answers even more stronger conclusions for people to work with. Before people toddle off, I'd just like to I'll share my screen again. Actually, I don't know why I stopped sharing. It was a bit weird because I can there's a couple more things I can share with you on Menti, and then I must finish by talking about Hacker. So coming up in the next couple of huddles, we've got an analyst's perspective on the FDP, and that's Matt Oates from Sherwood Forest Hospitals NHS Trust. I think that's next time. And then we've got Tom Prendergast from the Health Foundation. He's talking about waiting lists, MDS. We're looking forward to that. Tom is also at Hacker. Matt might be as well, actually, come to think of it. And there's lots more coming up as well. So, and I really must change this picture because it's quite old now and people don't look like that anymore. They look less hairy. That was also post-pandemic. So just a couple of updates. So we are still calling for participants for the expert elicitation exercise, which is supporting the new hospital programme. I'm going to share some information with that on that with you after in the post Huddle comms. And I asked last time who is anyone's done any modelling on dementia. We have an ICB who's looking into that at the moment, and also I'm collecting information on pharmacy analysts as well. So I'm just going to mention the Hacker, and then just before I know we've reached time, but I'm just going to share one last little thing with you. It is on the 3rd and 4th of December. It is all it's there now. The program is 99% there. I've just got a little bit more juggling to do, like I said before, some of our international contributors. I'm just forgetting what this is. No, it's actually in PowerPoint, isn't it? So we've got 8 keynotes, we've got 20 the longer sessions, 38 lightning talks, 7 workshops, 3 panels, and those slots are no longer available. This is for a different purpose, and 2 interviews and 60 posters. So we've got some really excellent content coming. This is just a little bit of a whoosh through what we've got on day 1 on the first morning. There you go. It's arranged by the overarching theme is rising to the challenge, analysis at the heart of health and care systems of the future. And now this is how we've themed it. So we've themed it in sort of along the shift of the community, improving system flow and targeting care, advancing analytics. And we have our workshops and our posters as well. So this is just a fleeting glance at everything that we have coming up for you. You might see your name there if you've got a few to be confirmed there. These are actually confirmed now, so that's even more exciting. And we've got the same for day 2. This is day 2 morning. There is a lot of really good quality presentations for you to come and enjoy. So make sure you get signed up. And oh look, there's Stephen. I forgot you were on here, Stephen. So here are 8 keynotes as well. So really looking forward to that. That is it, folks. Only 2 minutes over. Thank you again, Stephen, for sharing that with us, and thank you everybody for coming. And I'll see you in exactly 2 weeks, minus 60 minutes, something like that. Okay, thanks again.